All righty, welcome everyone. Happy Valentine's Day, first and foremost. You could be anywhere tonight with significant other, et cetera, but you chose to be here with us, and we're very grateful. We're very grateful. This is going to be a really terrific program, what clinicians want to know, addressing current questions related to the management of renal cell carcinoma. I've got some very dear friends up here on the stage with me, Dr. Tom Hutson, who's actually starting up a cancer center in West Texas, which is super exciting. Tian Zhang, who I've also known for eons, who's a very dear friend, first from Duke and now at UT Southwestern, where she directs clinical research. Rana R McKay is a professor and associate director of clinical research at UC San Diego. Work in close proximity with each other, share a lot of patients. I feel very fortunate to have that very close relationship. And I'll be your moderator this evening. My name is Monty Pal, and I'm a medical oncologist at City of Hope in Duarte, California, in Los Angeles. We've got a couple of disclosures, and these should actually be available on your personal iPads there as well if you wanted to dive deep into these for some reason. There are my disclosures there. We really want to thank our supporters for this program tonight, Bristol Myers Squibb, ESI, and Exelixis, and of course the Research to Practice CME Planning Committee and staff and reviewers, just a really terrific group of folks who have helped us assemble the program for tonight. We are going to be discussing some non-FDA approved uses of agents and regimens for renal cell carcinoma, so please do bear that in mind as we're going through the presentation this evening. So again, our title today is What Clinicians Want to Know, addressing current questions related to the management of renal cell carcinoma. We have an action-packed agenda, and we have questions that will pop up along the way that were actually generated through a very detailed survey of about 50 medical oncologists. So they all supplied opinions and advice around what they really need help with in their day-to-day practices, and we're going to try to field a lot of those questions as we go through the program today. Our program is as follows. We gave the toughest task, I think, to Tom. So Tom's actually going to have to squeeze within 10 minutes. He only gets 10 minutes, I want to emphasize, to cover localized and metastatic frontline treatment for metastatic clear cell renal cell carcinoma. Actually, none of these are easy to cover in 10 minutes because there's so much going on, but Tian's going to next cover management of relapsed and refractory renal cell carcinoma. We're actually devoting a whole 10 minutes to HIF-2 inhibitors, and Rena's going to be walking us through that, and I'm going to be focusing on one of the areas that's kind of near and dear to my heart, which is non-clear cell kidney cancer. So first up is Tom, who's going to walk us through localized and metastatic clear cell RCC in 10 minutes starting now.
Wow, thank you, Monty. It's my esteemed colleagues. It's great to be here. Thank you for being in the audience. We certainly are fortunate, and our patients are fortunate of the advances that have happened over the past 20 years in the management of kidney cancer. We often say we have an embarrassment of riches, and so meetings like this really bring that to bear as we develop new therapies and we try to understand what's already on the market and form combinations and move forward. So I've got the task of running us through frontline therapies and updating us all in the room about where we are today, which I think will be a great bridge for tomorrow's sessions because we're going to be adding to the data set that we go through today. So let's start off here with what we would call the adjuvant space with long-term phase 3 Keynote 564 trial. The studied schema is shown here. Just to remember, this was a clear cell RCC, no prior systemic therapy. And this was a trial that enrolled patients with various degrees of risk of recurrence from what we would consider a lower risk of recurrence, which would be a T2 kind of high-risk features, which may have a risk of recurrence of roughly around 30% or so, all the way up to probably the highest risk group, which would be those which would be the T4 tumors or the ones that are resected metastatic sites or resected NED population, which may have a recurrence rate of as high as 90%. So it's quite a broad risk. Patients were randomized 1-to-1 to receive Pembro 200 milligrams every 3 weeks for 1 year, which is roughly 17 cycles versus a matched placebo. The stratification factors were shown there. And as we all know, the primary endpoint was disease-free survival by investigator. But the key secondary endpoint that we often use to base whether we're going to use this in clinic is its impact on overall survival. Other secondary endpoints were safety. This is a Kaplan-Meier curve of the overall survival curve as it stands now out with past 48 months of follow-up. You can see the landmarks from 12 months, 24 months, 36, and 48 months. They track nicely. In the greenish turquoise curve there is the Pembro curve, and it's pembrolizumab curve, and it shows separation that happens at about 1 year and is maintained throughout after 48 months. And you can see the overall survival median has not been reached, but the hazard ratio, at least with median follow-up of 57.2 months, is 0.62 with a statistically significant p-value of 0.002. So it did reach statistical significance there, and we're waiting to get the median results and future updates. This is updated disease-free survival. Here, looking at that, the hazard ratio is 0.72 with the median follow-up of 57.2 months, again with not reported median numeric numbers. When it comes to safety, a lot of us look at that because we want to understand how our impact on choosing therapy in a population of patients that otherwise may be cured and they may not be willing to endure or suffer side effects, and certainly we don't want to give them side effects in the setting that they have potential cure from therapy, as shown here. As one would expect, and what's really surprising to me is the number of side effects that you actually get in the placebo arm. So if you look over there, any cause adverse events is 91.3% in placebo. I always call that the side effects of life, Monty. It's just, that's the side effects of living. You're going to report various different toxicities. It's a little bit bump up with pembrolizumab, a few percentage points, and as expected from all of the trials we've done with pembrolizumab, we know it's a relatively safe therapy for the majority of patients. We've come very attuned to how to handle toxicity, and I see no further updates, no additional toxicity with further follow-up. And it's worked its way into the adjuvant setting here for both stage 2 and stage 3. You can see it's listed there. Please note that this is for clear cell only. Again, that's trial population did not include non-clear cell. So moving into the first line, advanced RCC, latest data, we want to start off with our most recent updated NCCN guidelines, which are useful in the sense that you can't go wrong if you choose one of these category 1, but it doesn't really help us necessarily choose between the nuances of our therapy, and there's no randomized head-to-head trials to date. So really it is your choice, but there are some different nuances of the therapies that we'll try to bring out in my quick presentation. This is systemic therapy for non-clear cell histologies, and of note, please note that the IO-TKI regimens of cabo-nivo and lenvatinib pembrolizumab find their way as a preferred regimen and oftentimes become what we use in clinical practice now. Ipi-nivo, the long-term follow-up of that only IO-IO combination, comes from ASCO GU 2024. This is the way the study schema looked. It was a 1-to-1 randomization. It was measurable disease, good performance status, again, clear cell component, and patients got randomized to the nivo-ipi combination as shown there versus the old standard of care sunitinib 50 milligram 4-week on, 2-week off. This is overall survival by IMDC risk groups, and you can see, as we've expected in kidney cancer, with our IO TKIs, the biggest bang for the buck is going to be in the intermediate poor risk patient population. Of note, that represents up to 80% of what you see in clinical practice. That group of favorable risk patients with 20%, when we look at overall survival, there's by IMDC risk, we do see a little hints of a benefit there, and that benefit has prompted the listing of Ipi-nivo as a potential role for patients with favorable risk. And if you recall, that trial did include some favorable patients, but the take-home message that we've all lived with IO-IO is predominantly for intermediate and poor risk. But again, with longer follow-up and impact on overall survival, where a little bit of the shake-up and why it wasn't fully embraced is shown here. If we look at progression-free survival, Kaplan-Meiers, again, significant impact in that intermediate poor risk group, as you would expect. It's that favorable risk group, which has a funky thing where it kind of crosses over and actually seems like if you get the Ipi-nivo, you don't get as good as a result with PFS. Again, the survival benefit is why it's been given, it's listed as a potential option, but it's not given category 1 in the frontline setting and the guidelines. Axi-Pembro's update, most recent Keynote 426 is from 2023. Again, very similar eligibility criteria. This was, and for all comers, IMDC risk, favorable, intermediate, poor, but you needed to have clear cell. Stratification factors are shown there. Randomized 1-to-1, Pembro 200 IV every 3 weeks up to approximately 2 years of therapy, which is 35 cycles, or the Axi 5 milligrams orally twice a day. Again, the comparative arm was the gold standard of sunitinib. There's had a dual primary endpoint, so it was different than the Ipi-nivo trial of progression-free survival as well as overall survival and intent to treat. They also looked at response rate and duration of response as well as safety. If we look at efficacy in the favorable risk group, and shown side by side are the Kaplan-Meier's for overall survival and progression-free survival, again, we see a phenomenon that was somewhat seen with the Ipi-Nivo. That favorable risk group is really hard to show survival benefit in because they seem to do good no matter what you do with them. They do good with cytokines. It's that intermediate and poor risk group that really seems to have that benefit. Strikingly and different than what we see with Ipi-Nivo, and this was our first rally into this, was that we actually see a CR rate of about 13%, a PR rate approaching 60%, which gives you a clinical benefit rate up there in that 70% range. And then if you add stable disease in there, you're getting up into that mid-80 range. So this is one of our first therapies where the majority of our patients are going to have some type of benefit with at least stable disease, and clearly showed superiority over sunitinib. When we go into intermediate and poor risk, again, the story expands more, where we actually see the most profound benefit in that intermediate and poor risk patient population. Again, still a CR rate of 10% and a good clinical benefit rate. Cabo-Nivo. I'm trying, Monty, I'm trying. Checkmate 9er trial, okay? I'm talking fast. 650 patients are getting randomized, clear cell component, any risk. Cabo-Nivo's dosing showed there, 240 every 2 weeks. Cabo at 40 milligrams. Remember, that's less than what single agent Cabo is normally at 60 milligrams, again, compared to the sunitinib traditional dosing there. This is PFS by blinded independent review, and then shown next to it in the Kaplan-Meier is the overall survival. Again, we see PFS in the intent to treat population looking great. There's separation for the favorable risk group. In the overall survival, again, seeing what we're kind of used to now, difficulty in showing clear separation of curves when it comes to overall survival in the favorable risk group. We see great levels of activity, even a higher reported CR rate of 16%. Again, clinical benefit rates in that 85 and 90% when you add in stable disease. And this is now intermediate poor risk, again, better impact there across the board, and again, a very brisk CR/PR rate compared to sunitinib. We are going to see updated results, so I'll refer you to Dr. Moch's presentation tomorrow, where he's going to give the final follow-up results from the Checkmate 9er trial. And this is what the abstract shows here, just to point out that we're now seeing CR percentage rates maintained at 16.2% for favorable, 15.4% for intermediate, and poor for 6.6%. You can see the median PFS and overall survival shown here for both all three of those IMDC risk groups. As shown. The median overall survival is 53.7 months in favorable and goes down to 34.8 months in poor risk. Lenvatinib Pembro, this is the present final overall survival from the JCO publication and patterns of progression in ASCO 2024. What we see here in the IMDC risk groups, you got favorable again, kind of that superimposed, overlapping, difficult to show. Intermediate and poor, we do see impacts on overall survival, but there's a funky thing that happens at the end where you see a kind of a crossover. We actually were able to show when we do statistical maneuvers that if you block for prior post-progression therapy, which may be different among countries, you actually see the curves maintain separated. But again, that's a post-hoc analysis. If we look at progression-free survival, again, the biggest impact is going to be shown here in the intermediate poor risk, but you also see that great impact in favorable. We do have median progression-free survivals now in the poor risk group of 22.1 months and the favorable risk group of 28.6 months. This is what's been reported previously, which is essentially showing that the more tumor shrinkage you have, as measured by response rate, the greater that impact's going to have on overall survival and best, as well as overall. And the next step in the analysis is actually what Victor's going to be presenting here as an abstract tomorrow, where he's now going to expand that analysis to look at changes in IMDC. So if you're an IMDC score intermediate or poor, do you actually improve? How does that correlate with response? And he's going to look at impact on tumor progression in the responders. The Cosmic 313 trial, sorry, Monty, this is a triple trial here, which is adding Cabo into the mix. And as you know, this was an interesting trial because it was one of our first triplet trials to see if you add a TKI into the IO-IO, can you get the benefits of both? A tail of the curve when it comes to overall survival, but a greater response rate that would be more beneficial to patients. And this is what we see in the final PFS analysis, a nice clear and separation between the curves here. But what we do is that great benefit that we've seen previously in those poor risk patients seems to go away. Not too happy about that, right? Because we've looked at intermediate poor with traditional IO-IO and IO-TKIs that look much better than that, which has really prompted the discussion, what really is the value of adding those in? And so we're going to see a final results by our friend Dr. Albaguiz from Institut Gustave Roussy presented tomorrow, where she's going to update the results of the Cosmic 313 trial. This is what's been shown in her abstract here, with a median overall survival of 41.9 months for the triplet, but 42 months for the placebo, Ipi-Nivo, suggesting, again, not a really benefit in the overall survival when it comes to this regimen, which I think, although there may be subsets that provide unique benefits to patients as a general therapy option for all of our patients, is probably not correct. And then finally, and my last is just to update us on really interesting trial, Checkmate 67T, which is now looking at subcutaneously administered IOs. So nivolumab subcutaneous 1,200 milligrams plus whatever the recombinant human in pH20 is every 4 weeks versus Nivo IV. That's the carrier molecule for it, to give it subcutaneously. And they did this trial to see if it was a non-inferiority. Could you use a subcutaneous? And there may be benefits, practical benefits for patients, you can imagine, especially those that travel great distances. There's shorter infusion time and whatnot. And we see it's a superimposable curves, progression-free survival, hazard ratio 1.06. So it meets that threshold of being a non-inferior option. And it resulted in regulatory approval in the United States. So nivolumab is actually approved here for use as of probably 6 months ago or so in the United States. Thank you, Monty.
Wow, how about a big hand for Dr. Hutson?
Thank you.
No, that was stellar. And it would have been impossible, I think, to cover that in exactly 10 minutes. Tom barely went over here. And I think we've actually still got quite a bit of time for some really rich discussion here. So there's some terrific questions that have been submitted. For Valentine's Day, we're going to do a little special thing. And I'm going to ask, the current version is listed here on the slide. And I'm going to ask a slightly twisted version of these questions. It's a little more complicated, okay? So maybe I'll start with you, Rana. So let's say a patient comes to your practice with metastatic clear cell RCC, sarcomatoid disease. What would you typically recommend as frontline therapy? Do you always suggest IO up front?
Very good question. I think we've done a lot of work looking at biomarkers in RCC, looking at DNA signatures, RNA signatures, blood-based biomarkers, but quite honestly, the most clinically relevant biomarker that we have in the clinic right now is actually the presence of sarcomatoid dedifferentiation on people's pathology as being highly predictive of response to immunotherapy. These patients do quite poorly, or historically have done quite poorly with TKI monotherapy, and I think this is the one area where I would absolutely, do IO, even in a high volume individual.
Yeah. I mean, I think that's totally fair. Tom, I'm going to ask you the hard version of this question. Patient comes into your practice back in 19. Okay. They had pathologic T3A disease resected. You see that in the specimen, there's about 30% sarcomatoid features. You continue to monitor the patient, as we always did back then. We didn't really have adjuvant options, right? This patient comes back to your clinic 6 years later, right? And he has metastatic lung disease, 5 or 6 lung nodules beyond the scope of any local definitive therapy, okay? And you do a biopsy and all you see is a clear cell component. Would you necessarily restrict yourself to Nivo-Ipi in that setting? Remember, the patient had sarcomatoid features originally. What do you think?
Well, I think the path is pretty good. That's a good question, but, you have to rely on your path. The path resected a nodule. If it was a full resection versus a needle, may sway one way or the other. But I think going IO-TKI or IO-IO would be fine. But, you could make a case for either way. This would be an ideal candidate for an IO-IO, so I would generally utilize that strategy in my practice because the low volume pulmonary disease, I think, would be quite exquisitely responsive in that setting.
Yeah, and I think you presented the data for favorable risk patients getting nivolumab and ipilimumab, so I guess that sort of supports that notion, right, to some extent. Yeah.
Exactly.
Absolutely. Okay, so, question for you, and this is actually something that we're going to have to be dealing with increasingly in the clinics. A patient comes into your practice and they progress within 12 months of therapy of adjuvant pembrolizumab. So let's clarify the scenario here. I'll make an example of a patient who had pathologic T4 disease, right, had resection. Tian, you put this patient on adjuvant pembrolizumab, totally reasonable after appropriate counsel, right? And let's say at the 9-month mark, while on adjuvant therapy, they progress. What are you going to do for them in that setting?
Yeah, so it's a great question, and one that comes up in our practices quite a lot, as you allude to. And so for that patient who's primary refractory to PD-1 therapy during that first year on adjuvant treatment, I would switch mechanisms. And so I would not prefer an IO-based combination. I would probably move more toward cabozantinib and balone.
What do you think, Rana? Same for you?
Yeah, I completely agree. I think now we have data from CONTACT-3, we have data from TiNivo-2, basically showing that layering in or continuing the IO agent post-progression has really not actually been shown to be beneficial. And I think in the context of somebody, we're data gap zone with regards to what happens in the adjuvant setting, but if somebody is actively progressing on pembrolizumab, they're 9 months into their adjuvant course of treatment, I would stop the pembrolizumab and transition them to a single agent TKI.
If you don't mind, I'm going to stick with you, Rana, and make this a little bit harder. Okay.
Yeah.
So, this is actually something that I came across in my practice.
Yeah.
So, very young patient with pathologic T3 disease, right? They go to surgery very quickly. I get them started on adjuvant pembro afterwards, right? They're in their mid-40s, very anxious. They really want to get treatment going. The patient actually has an early set of scans, right? Just again to alleviate their anxiety at 6 weeks, and I see that there's 4 new lung nodules in that setting. So they're within the first 3 months of therapy. They've just gotten going on adjuvant pembrolizumab. What do you do in that setting?
Well, I'd biopsy the lung nodules to prove that it's metastatic disease first.
And it is.
And if it is metastatic disease, I probably would put them on IO TKI.
What do you think, Tom?
I agree.
Yeah. Okay, good. That's what I did. Excellent.
Okay.
Perfect. Okay, now Cosmic 313. Tom, you presented the data. And of course, Laurence is going to spell it out in more detail. Is it practice changing, yes or no?
No.
No. Tell us why.
I just don't think we saw the magnitude of benefit that one would want with the addition of a toxic and costly third agent.
Okay. So Tian, a patient actually flew out to ESMO a couple of years ago. They saw Tony's presentation on Cosmic 313. The first time around, they said, well, there's a PFS benefit here. They convinced their oncologist to start them on Cabo, Nivo, Ipi in routine clinical practice. And we've seen this happen, right, on occasion. Sometimes I'll get, second opinions where this is actually being done already. And, you see this data. What would you advise them? Let's say after 6 months of therapy, they've got stable disease on this regimen. Do you drop any component of what they're on at that point?
Well, at 6 months, they've already finished their Ipi-Nivo portion, right? So they finished their 4 cycles, hopefully. We'll see tomorrow, but there are some lesser, perhaps, harder ways to get all the doses in that first 3 months. But at 6 months, presumably they finished their Ipi-Nivo portion, and now they're on Cabo-Nivo, right? So they're just on the doublet. So if they have stable disease, I would probably just keep them on Cabo-Nivo at that point.
What if they're really struggling with the tox of diarrhea or something of that sort, Rana? What would you do in that setting?
Well, I think I would try to tease out, is it IO diarrhea or is it Cabo-related diarrhea? I probably hold the Cabo. Is it getting better? Is it not? If it's kind of like continued, ongoing, kind of persistent, and I don't think that there's a temporal relationship with the Cabo, I probably would get them set up with like a GI referral and colonoscopy to see if they've got some like occult immune-mediated colitis. But, I would basically manage that patient as if I had them on Nivo Cabo from upfront.
Got it.
I think Tian's trial will help us answer what Cabo or a TKI like it would do as a salvage approach to patients who may not have ideal response to Ipi-Nivo by adding that in at the point of progression, right? So that's a cool thing. I would hope that people don't just start off triplet therapy in people. One, it's not NCCN recommended. It's not going to be covered by insurance companies. That's a triplet regimen. So
I think it's an important point. We've got to really discourage that practice. And I think, Tian, you got some nice slides on your
we'll
trial.
talk about pedigree in a second.
Yes.
Excellent.
See,
Excellent. Very good. You read my mind. So now we're going to shift to other clinical scenarios that unfortunately we run into quite often. So patient comes into your practice, Rada, they've got aggressive bone metastases. Let's say, you get one of these bone scans, there's disease up and down the spine, right? You see that in addition to that, these bone metastases are painful, patient symptomatic. Does that sway your choice of frontline therapy? What might you go with in that context?
I think if somebody is very symptomatic from their disease and has, we've seen these patients that come in and they present with a skeletal related event up front. That's a situation where I'm not necessarily leaning towards getting that person on IO. I think they actually have benefit from the TKI up front with control of their bone metastases. So in these patients that have high volume disease, highly symptomatic disease, with bone mets, and we've seen the data for cabozantinib activity in the bone. I think I tend to lean towards potentially using that regimen in this context.
Yeah.
And making sure they also are on a bone protecting agent, whether it's Zometa or denosumab, and they're getting adequately controlled from a bone standpoint.
It's actually a good point around bone health, something
Yeah.
that we don't always think about in the context of renal cells. So I'm glad you mentioned that. Tom, I'm going to give you the tough version of this question, okay? Patient comes in to see you with high volume lung metastases. The patient actually has scant hemoptysis, right? Says, oh, I'm coughing up a little bit of blood here and there, right? And you do a scan, you see that there's potential endobronchial metastases, you send them to pulmonary, they do a bronchoscopy, identify the same. What do you start with in that setting?
I'm starting with an IOTKI also, and I've had the pleasure, like most everyone on the stage, of using all the different regimens, but my kind of go-to in this setting of high volume disease where I need an immediate response is going to be Len-Pembro.
Interesting. It's funny. I might differ with you a little bit in that. And we were taking a trip down memory lane earlier.
Yes.
And you remember all the initial angiogenesis inhibitor studies where there was some risk, particularly in the context of lung cancer, right? With bronchial lesions, bleeding, et cetera. This is one of those settings where I tend to use Nivo-Ipi more often. Rena, what's your lean?
Yeah, I think that if they are actually having like frank hemoptysis or they've got like an invading lesion, like I'm not keen on that TKI up front. I think it also depends on what their burden of lung disease is. I think if they have a high burden and I'm worried that I won't be able to get them to second line, then I will take the risk and put them on IO-TKI. But if they're not hypoxic, you've dealt with the bronchial lesion with either SBRT or through interventional pulm, kind of doing some sort of intervention, then I absolutely would lean towards IO-IO.
Tom?
Just a counterpoint. So, you'd have to be prepared, though, of, clearly Ipi-Nivo has the highest, best response of progressive disease in that group. So, that's my biggest concern with that. So again, to Tian's trial that she's going to talk about here, adding in something. So if you did those first 3 months of Ipi-Nivo and you're just not getting a response, you're not seeing that clinical benefit, which can happen more frequently with that regimen than an IO-TKI, being able to add in something may be ideal for that patient population. It kind of serves both then.
Tian, we need you to give us a sneak peek of your study tonight. Tell us what it's early so we can address some of these scenarios. So question for you, and actually, Rena, this comes up a lot in our neck of the woods with this particular regimen, lenvatinib and pembrolizumab. I've seen all permutations of this. When you start Len-Pem, what doses of Len are you using?
I start with the 20 milligrams. I think I kind of try to be a purist with that. I tell the patients, I'm going to start you at 20 milligrams. You're most likely going to be dose reduced. The majority of patients get dose reduced. It's okay. Just let us know about your symptoms. I tend to start at the recommended dose and then modify.
And I feel like we might have traded notes on this before, and maybe even seen some of the same patients, you being in San Diego, me being in LA. I've seen a lot of practitioners who actually start at 10 milligrams or 12 milligrams, doses they may be familiar with from hepatocellular, perhaps other indications. My personal take is they're sort of shortchanging the patient potentially of some, ultimate survival gains. So Tom, I'm going to throw a tough question to you here. Let's say you see a patient, right, in your clinical practice who comes in, let's say at the 3-month mark, they were started by another provider on lenvatinib 10, right, with pembrolizumab, and at the 3-month mark, they've got stable disease. They're doing okay. Do you ramp up the dose at that point? You would. Tell
I've
us
talked to
more.
the patient. It's informed decision-making with the patient, and we go through the goals of therapy. If your goal is just stable disease, and you're risk-averse, and for side effects, then I would stay there. But if they're, if they want to try to get more shrinkage, then I would try to talk them at least trying the higher dose. You can always go back down if you needed to.
Tian, what do you think?
Well, so in my neck of the woods, I find it hard to get people access when we're dose reducing. And so I often, will say, 20 milligrams is a great standard dose. Sometimes, if I'm worried about getting those dose reductions in early, I'll start at 18 in order then they have the packet with the 10 and the 4 and the 4, so then they can dose reduce easier, especially if they have somewhat borderline hypertension at baseline, and I know we're going to get into trouble really quickly.
Oh, that's interesting.
But Monty, you were kind of the leader of a trial that was done of the other formulation of lenvatinib, which is when it's combined with everolimus, and that was a big question. Could you get any efficacy? Was it better to start at a lower dose when it came to outcome efficacy of that regimen? And you showed definitively there's not. So you don't buy anything by starting at a lower dose with it. So I agree with everyone. We need to, as a field, just say, let's start off at 20 milligrams. Tell our patients that 2/3 of these patients will require a dose reduction at some point, and you know what? That is okay. We're gonna adjust the dose to what your body needs, and we'll know that in you as an individual. Because I'm not smart enough to predict little Tian, sweet Tian, what dose she would have versus big burly me. It could be completely different. You can't predict based on body size or
I think that's an excellent point. I'm glad you brought up that study, Tom, because what's really ironic is that we looked at 14 milligrams versus 18 milligrams. It would have seemed implicit, right, that you'd see better tox with the 14 milligram dose. Almost no difference in terms of grade 3, 4 treatment emergent adverse events, which really struck me as being odd at the end of the day. It was a big study, 300 patients, right? So it was actually a relatively sizable experience. Maybe I'll stick with you, Tom, if you don't mind, since you have a lot of familiarity with the CLEAR trial being a big part of that. And I think what's noted here by one of our community partners is true. It seems as though experts aren't particularly bullish on lenvatinib and pembrolizumab, despite, the PFS in that trial hitting 2 years. What do you think that's all about?
Doesn't seem that experts are that bullish, meaning that they're not wanting to utilize it.
They're not super excited about it, yeah.
I don't know, I'm personally very excited about that regimen. Some of it goes to, experience. When you're the last one on the market, sometimes it's difficult to change practice patterns. I mean, clearly there's a sizable number of people that use Axi-Pembro as a regimen. They just don't try anything else because they've had great experience with it. They feel comfortable managing the side effects. And I think as a community of experts, without those randomized head-to-head trials, we've kind of supported that. We've said, hey, get to know one of these regimens. I'll use Tom Powell's as an example, who'll always say, just use one of them. They're essentially the same. Get to know one of them and know that well, and have that be your go-to. And that's what we've preached. So it's not unsurprising, and that's the way people interpret the way we are. But for me, I use Len-Pembro as my primary go-to, and probably Cabo-Nivo would be my second of the IO-TKIs.
Yeah, I'm probably more in the Cabo-Nivo camp up front. I tend to do that more, just based on quality of life considerations. You're starting at a dose of 40 milligrams, which I find to be much more tenable.
I think we agree they're both good regimens and can provide benefit.
Absolutely. We're going to kind of go rapid fire through these questions that are noted here, and actually we had a little bit of a healthy discussion around this when we were sitting together planning for today's meeting. Sub-Q Nivo, Tian, where does that sit at your institution currently? Is this something you're using commonly in clinical practice?
Not quite yet, although I think we're slowly, as our treatment rooms are pretty full, our infusion rooms are at capacity. I think it's a good way to toggle between needing a full 30-minute, 60-minute infusion slot versus a fast track. Chair time is really important in a lot of our practices. So I think it's a reasonable substitute in the right situation.
Fair enough. Actually, it looks like one of our community partners did my work for me and came up with a pretty tough zinger over here. So, Rana, a patient comes to your practice after having had renal transplant, develops, let's say, a recurrence of metastatic, localized renal cell carcinoma, high-risk disease, gets resected. Would you put that patient who's post-renal transplant on adjuvant IO, assuming they meet parameters based on stage, grade, et cetera?
I think when we talk about adjuvant therapy, we got to talk about what is the patient's risk of recurrence, and also talk about what is that patient's longevity, what is their survival. I do have concerns about somebody who's had a transplant, is on immunosuppressive medications, and then you're giving them an IO treatment in an adjuvant setting where you're likely over-treating. And at the end of the day, if we look at sort of like the number needed to treat versus the number needed to harm, like, you're going to probably cure 1 in 10. You're going to probably give an IRAE to 1 in 10. And so, in somebody that has a renal transplant, I feel I'd be hesitant to give adjuvant therapy too.
I completely agree.
Yeah.
And it's just so unpredictable what you're doing in that setting, right? Patients on tacrolimus and other immunosuppressives. What are you really garnering from giving adjuvant Pembro in that setting? So I totally agree. This is just a quick rapid fire question, Tian, for you. Adjuvant pembrolizumab, can you use a shorter duration?
I would give it as intention to treat on the 564 trial, which was for 12 months. If they're getting toxicity and side effects at 6 months, that would be a reason to stop, but not purely for just intention for 6 months.
Totally agree. And Rana, you've done a good amount of work in this space. So I'm going to throw this last one to you.
Yeah.
ctDNA for adjuvant pembrolizumab. Thoughts?
Not ready for prime time. Our assays are not great.
Not ready for prime time. That's right.
And you can't really make any decisions based off of it. So I don't think that right now we're not there.
Excellent. Well, I think we're right on time here. I'm looking forward to this next talk. You've heard several comments already alluding to some of the studies that Tian's going to introduce to us, but Tian's going to walk us through relapsed and refractory renal cell.
Great. Thank you so much, Monty. So I'm happy to be talking with you all about relapsed refractory kidney cancer tonight. Tom just walked us through a really nice look at how we manage frontline disease. And to me, when we're thinking about IMDC criteria, when we're thinking about this aggressive inflamed disease and starting that first-line metastatic treatment, we are trying to change our patients' disease biology and also their outcomes, right? We're pushing out those curves, we're delaying progression, getting patients to live longer. So in my mind, this is sort of making an inflamed disease and more aggressive disease into a better, more indolent disease. And then over time, these patients will unfortunately acquire resistance. And so what kind of data do we have now then to support sequential treatment as patients are developing resistance to frontline immunotherapy-based regimens? So certainly refractory disease occurs after frontline immunotherapy doublets, and what's the data? Many of these registrational trials in the refractory setting were done prior to us having immunotherapy doublets, so take it with a grain of salt. However, there are 6 approved regimens in the refractory setting. We'll harken back all the way to the AXIS trial, which was axitinib versus sorafenib. We talked a little bit about sorafenib earlier tonight, but METEOR was cabozantinib versus everolimus. Checkmate 025 was our first immunotherapy trial in the refractory setting that was nivolumab versus everolimus. Study 205 was probably the oddball out in this lineup. It was a 3-arm phase 2 trial of lenvatinib everolimus versus lenvatinib alone that gained the approval for lenvatinib and everolimus. TiVo-3, the most recently done VEGF inhibitor trial, tivozanib versus sorafenib, and then LIGHTSPARK-005 was belzutifan versus everolimus. So you see across the board here, most of these are compared against everolimus as a standard of care in the refractory setting, some against sorafenib. Objective response rates, right, in the sort of 12 to 25%. I would say study 205 was a oddball out again, given the small numbers. It did have a response rate of 43% for combo-treated lenvatinib everolimus-treated patients. And so we have all these potential options to use in the refractory setting, and they were mostly approved on that primary endpoint of progression-free survival. So here I'm showing you 4 of these curves. AXIS was axitinib that improved progression-free survival over sorafenib. TiVo-3, tivozanib, improved progression-free survival over sorafenib. METEOR on the bottom, cabozantinib improved progression-free survival over everolimus. And then lastly, LIGHTSPARK-005 was belzutifan, which Rana will get into in the next segment. All right, so what not to do? So these are 3 less successful trials in refractory disease, and we've certainly learned a lot even from negative trials. So CONTACT-03 was cabozantinib with atezolizumab versus cabozantinib alone. TiNivo-2 came out last ESMO about a couple months ago. Tivozanib with nivolumab versus tivozanib alone. And then CANTATA, many of you may remember this trial, was a combination of cabozantinib with telaglenastat, a glutaminase inhibitor compared against cabozantinib. And what I would also say about these negative studies is that cabozantinib alone is a really good monotherapy. It has been a hard monotherapy to beat. As you see, these PFS, median PFSs are very similar across these treatment cohorts, and then also the median overall survival, those hazard ratios, right, are right around 1. All right, so lesson learned from CONTACT-03 and TiNivo-2 is that PD-1 and PD-L1 inhibition after prior progression on immunotherapy does not improve progression-free survival outcomes. And so I would advocate that we all stay away from using more immunotherapy doublets when patients have progressed after frontline IO doublets. What are those novel sequencing and therapy approaches? So as you heard Tom allude to earlier, we'll talk a little bit about the Pedigree trial that has finished accruals in the cooperative groups. Lenvatinib, belzutifan with Keymaker UO3. This is a basket phase 2 done in the refractory setting that we will hear from Dr. Albigez tomorrow morning, and Dr. Beckerman. I think Dr. Beckerman is presenting that one in the oral kidney cancer session. Zanzalintinib, I'll walk you through a little bit of data that we have from Stellar 001, and then I'll tell you a little bit about Boost RCC, which is a investigator-initiated trial that I'm running at UT Southwestern. And then we have some radioligand therapies that are interesting. Starlight 1 is a CA9 targeted girentuximab agent that is coming also in the refractory settings. So what does Pedigree look like? Pedigree is an adaptive phase 3 trial that we ran in the Alliance Cooperative Group and across all NCTN centers, enrolling patients with metastatic renal cell carcinoma with a clear cell component, no prior systemic therapy, with IMDC intermediate or poor risk disease, and taking everybody to frontline ipilimumab with nivolumab. At the 3-month mark, they were assessed for responses, and patients who with complete responses received nivolumab alone, those with progressive disease received cabozantinib alone, and those with non-CR, non-PD, so anybody with a partial response or stable disease were randomized to nivolumab or nivo with cabo. They were discontinued if they had progression of disease, unacceptable toxicities, or complete responses at 1 year, and this is a treatment de-intensification endpoint that not many people have done as part of these frontline trials. Primary endpoint is a 3-year overall survival. The study activated, enrolled across the NCTN from May 2019 through May 2024, and I'm glad to say we finished with more than 1,100 patients and about 598 randomized ultimately. That's a number needed to randomize there, but we had almost 600 patients who were randomized. So we're looking forward to seeing all the events that occur, and until we do, we'll have some more updates for you, hopefully at ASCO this year. Boost RCC is a refractory trial that I'm running in the refractory setting, trying to improve on tumor antigen presentation using a PCSK9 inhibitor called evolocumab. Evolocumab was developed for treatment of hypercholesterolemia to improve LDL receptor expression, but it also happens to improve MHC class 1 expression and tumor antigen expression, and so we are combining that with nivolumab in the PD-1 refractory setting to think about how do we salvage patients who have progressed after frontline PD-1 therapies. We have finished stage 1. We have 10 patients that have enrolled to the trial so far, so we're following them for responses, and hopefully we'll see some to take us to stage 2. This trial is open at UT Southwestern and MD Anderson as part of the Kidney Cancer Research Consortium. All right, walk you through a little bit of the data that we have on zanzalintinib. We saw this data from Monty now almost 1.5 years ago at IKCS 2023. This was a trial in the refractory kidney cancer setting using zanzalintinib in either patients who had received prior cabozantinib or patients who had not received prior cabozantinib. And you see both in cabozantinib exposed patients as well as in patients who are cabozantinib naive. We see a decent amount of partial responses and also some stability of disease. So disease control rate, importantly, was above 80% for both of these cohorts, for both cabo exposed as well as cabo naive. So really important, I think, setting up zanzalintinib for a variety of registrational trials, and I'm really excited to see this next generation of trials with zanzalintinib read out over the years. I think there's a challenge for all of us in tackling refractory kidney cancer and those mechanisms of immune resistance. We do need to go after some of these mechanisms. Is it tumor antigen presentation? Is it T-cell exhaustion? Is it potentially macrophage changes in the microenvironment? Or is it completely something separate from the immune microenvironment milieu in general? So lots to do, and I think lots to learn as our patients are, many of them are progressing past frontline IO doublets. And if we do our jobs right, ultimately our patients win. Showing here a treatment of a patient who presented with kidney cancer when he was 54, developed metastatic disease in 2007, and has lived now 18 years with metastatic kidney cancer. He's seen multiple 10 lines of treatment for metastatic disease, including 3 interventional trials. He's even outlasted 3 oncologists. Lauren Harshman took care of him initially, then Sandy Srinivas across the way at Stanford, and then he moved to Dallas, and I have the pleasure of taking care of him now. And so this sort of describes to you sequencing life-extending therapies in kidney cancer really helps our patients live longer, even though we see progression-free survival intervals in our trials about 8 to 12 months. This is really meaningful for our patients. And so I'll stop there. Resistance to our frontline therapies occurs in many of our patients. PD-1 therapy, I think, has no role for post-IO treated and refractory patients, and we should change the treatment mechanisms for patients who are IO refractory disease. Tivozanib, belzutifan, and lenvatinib everolimus, as well as cabozantinib alone, are all approved options in this space. And we'll go from there.
Awesome job. Great job, Tian. Thank you.
Thanks, Monty.
So as I'd mentioned, we'll do the easy version of the question, then the hard version of the question. This is a scenario where you've got a patient with clear cell renal cell carcinoma who's doing great, actually, on a frontline regimen, let's say cabo-nivo, right? And Tian, maybe I'll throw this one to you. Let's say you do a CT scan and you see 2 new lung nodules pop up. What are you thinking in that setting? Are you going to sort of ditch that frontline therapy? Any other approaches you might suggest?
Yeah, if they're tolerating really well, and it's been a good amount of time on treatment with oligo progression, so 2 nodules in the lungs, I may send them to our radiation oncologist and think about radiating those oligo progressing lesions while keeping them on the regimen they've tolerated and been responsive to for a while. If they're truly not tolerating that regimen and we see, really symptomatic disease, those may be ones where I switch our systemic treatments.
Very good. Okay, I think that makes perfect sense. And then to just sort of spice it up a little bit, Rana, maybe I'll ask you, this is something I want to lean on you for since you have a lot of expertise with radiotherapy trials and so forth. Let's say it's not just 2 new lung nodules, but let's say it's 7, right? And do you take that case to the surgeons? Do you take it to tumor board and talk to radiation oncologists? What's a good, acceptable definition for oligoprogression?
Very good question. We just recently had a meeting where we posed this question to a group of KOLs, and I think the answer is there is actually no defined definition. I think when we think about the pan-solid tumor oligometastatic studies, typically 5 was used in the context of those trials. But I mean, this if somebody has multifocal disease progression, 7 new sites of disease, I think this speaks to a systemic process where I usually am leaning towards switching around their systemic therapy as opposed to offering metastasis-directed treatment.
Yeah, I think that makes perfect sense. There's a real art to it, isn't there? I mean, sometimes if you see that these 3 little lung nodules and 4 others are clustered into, sort of separate lobes that can be wedged out, you do it, right? You do it. Yeah. But agree with you that there's no hard and fast rule in this case of what oligoprogressive disease represents. Tom, I think Tian did a really excellent job of really sort of driving a, nail into this idea of doing immunotherapy rechallenge. But let's say, you see a patient who was on cabo-nivo in the upfront setting, okay, progresses on that, and then comes to your clinical practice on len-pembro. Let's say they're doing reasonably well with the toxicities and so forth, right? They've garnered stable disease after a period of maybe 9 months or so. You review Tian's presentation, which clearly says no need for IO after IO. Do you drop the pembro or do you keep it going?
that's a tough case.
I told you, yeah.
Because a lot of it's the patient trust. So, I mean, again, it's shared decision-making with the patient. What are they willing to suffer with? Because, heaven forbid, you drop that because of science. You say, there's no science to support this, and I would never have started it. But you drop that on the patient, and then they progress.
Mm-hmm.
So what have you done? That patient, has to buy into that, or you just haven't served that patient well.
Right.
So it's that same kind of discussion you have when you are trying to withdraw therapy from patients, and you're saying, okay, there's really no evidence of continuing on your therapy now. You've had this prolonged period of stable disease. Let's try to wean it back a little bit. And some patients just are absolutely would not want to do that, and others are game for it. So it's really a tough situation. But I would definitely be having the conversation with them in a low threshold to want to stop it. And that's what I would. I mean, it's a really tough decision. I don't think one answer fits each patient scenario.
What do you think, Rana?
I think it's challenging. I think actually recently Dave McDermott was giving a talk on this very topic, and we don't know what the right answer is, that there's probably a group of patients who actually do need to continue the maintenance, pembrolizumab or IO therapy, and some that can get by without it. We just don't necessarily have a biomarker to predict who those individuals are per se. So I don't think we have a right answer. I think it also depends on what's actually going on with the patient's scans. I think in my clinical practice, if somebody has a CR and there is no evidence of disease that I actually see on their imaging, we have excellent data that those people who get into a CR, the likelihood that they're going to end up then getting out of a CR is low. And so in that situation, I will say, you've got a complete radiologic response, we can peel back.
Yeah, that makes a lot of sense. This next one's a tough one. It's more of a hypothetical scenario since, as you pointed out, Tom, we're not doing a ton of Cabo, Nivo, Ipi in the frontline setting. But let's say you happen to see a patient who had been on the clinical trial, got all three up front, then has some evidence of progression. Let's say, I'll put a number to it here, after about 12 months of therapy with the triplet. What do you do in that setting? What's your next mainstay?
Well, okay, so we made the decision already that's been enough progression to warrant a change of therapy.
Exactly.
Then for me, it would be going to lenvatinib everolimus as a second line, generally is what I would do.
What if they struggled a little bit with the toxicities on Cabo on the study? That's some TKI-related issues. Will that change your decision-making at all? What would you do there?
So essentially, we have what I would say 3 really good therapies that we want to expose them to through the following lines of therapy outside of a clinical trial enrollment, which likely has one of those therapies in it. So it would be either lenvatinib everolimus, it'd be tivozanib, or it would be belzutifan. So I'd be looking at one of those options, and if they had a lot of side effects, it would be the decision would be, do you go with tivozanib, or do you go with belzutifan? And we really don't know what the right sequence is, and so I think you would ask a lot of doctors, you're going to get as many choices there.
Rana, what's your preference in that setting?
I think it depends. I think if somebody is really struggling with TKI-based toxicity and they've already been exposed to IO TKI, then I would consider potentially giving that individual belzutifan and seeing how they do with that agent. I think, if they are, having significant disease burden, significant disease progression, high volume liver mets, that's where I'm really leaning towards Len-Ev, where response rates may be a little bit higher. So I think a lot of it depends on the clinical scenario.
Yeah,
Got it.
exactly. Yeah.
Got it. We're going to make this next question here a little bit tougher by asking for one specific answer, okay? So you've got a patient who progresses on Nivo Ipi, and let's say they've got excellent functional status. They're doing great. They walk into your clinic, and despite progression on radiographs, which is substantial, right, enough to warrant a change in therapy, they still are ECOG 0, going to the gym every day. What do you recommend for them in that setting, Rana?
Clinical trial.
Oh, darn it. You got me. You got
always.
me.
I mean, I do want to put it out there is that honestly, like our treatments are not good enough. We need better treatments. And, the rationale around clinical trials is not just waiting until they're late stage to think about referral. I think RCC, it's a common malignancy, but it's not so common. And I think thinking about having a good working relationship with somebody that, maybe at an NCI-designated comprehensive cancer center where you can work collaboratively with that individual, I think it's really, really important. So I actually think that it is something to consider. They're young, they're healthy. You want to maximize the number of, bullets that you have in your gun that you're going to tackle this tumor with. So I think that it's certainly a viable thing.
I actually really like that answer.
Yeah.
I should have excluded it as an option. If I were smart, I would have done that. Tom, okay, I'm taking clinical trial off the table. What are you giving this patient?
Probably cabozantinib. You said they didn't get Cabo-Nivo first? So
No, they got Nivo-Ipi in the frontline setting.
Oh, Nivo-Ipi in the frontline setting. Generally, my practice pattern has been to give Cabo next in that setting.
And Tian, what if that patient came to your clinic in a wheelchair? They're ECOG 2, they're not so functional at home and so forth. What do you go into as your second-line mainstay in that setting?
Second line after Ipi-Nivo, I do also think about cabozantinib because I think it's a really good drug and can be tolerated quite well. I may dose reduce upfront. I wouldn't start at 60 for somebody who's quite frail.
Interesting. Okay, very good. And this next question that's being posed within the first bullet point over here really lends itself to Pedigree, your trial. So in this particular context, if you saw a patient who's progressing on Nivo-Ipi, would you consider maybe throwing in a sprinkle of cabozantinib there?
Well, that would not quite fit Pedigree because Pedigree, they would have sprinkled in Cabo, at 3 months and not wait until they progress. I do think this sense of when do we escalate therapy is an interesting one. If triplet, right, is too toxic up front, at least the Cabo-Ipi-Nivo one, and we are delaying some of that cabozantinib exposure, then when is the right timing? And so on Pedigree, we're taking people who are essentially stable, right? They have at least resist stable disease, and they're going into getting some Cabo sprinkled in at 3 months. So 5 months, and if they're really progressing, they don't quite fit that criteria, but I think either adding in or switching to cabozantinib would be my approach.
Okay, very good. I think that's very reasonable. Rana, I'm going to jump to this next bullet point over here, and let's envision a situation in which you do what I commonly do, which is to start a patient in the upfront setting on Cabo-Nivo, right? So a lot of us mentioned that maybe after Nivo-Ipi, Cabo might potentially be our mainstay. What are you using as second line in that situation? And you can give me one answer and not clinical trial.
Okay, one answer. Generally, it's Lenev.
Okay. Yeah, is that, I see you nodding your head, Tom, is that your mainstay as well?
Very much.
Yeah, what do you think, Tian?
Yeah, I think Lenev is a good option.
That's interesting. I'm using a lot of tivozanib in that setting,
Okay.
but I find that, functionally, sometimes it's a little challenging to offer patients Lenev in that context. Tell me scenarios when you might offer something different from Lenev, Rana.
Slow progressor, maybe a little bit more frail individual. Maybe they are really struggling with their TKI, then I would offer tivozanib. Same situation, I would probably also consider offering belzutifan. I think if somebody has seen IO, seen VEGF, I'm not opposed to earlier belzutifan use in select patients.
And I'm going to push a little harder on that one, Tom. Why Lenev? You presented the data to us, or Tian did rather, excuse me, from the trial leading to FDA approval. Just 150 patients, only 50 who actually got Lenev in that study. I mean, it's a really well done randomized phase 2, but it's a phase 2. Is the data trustworthy enough, you think?
In my opinion, being involved with that medication from the phase 1 experience onward, it has been. I've had great results with it. I've seen it work in the refractory setting in patients who were refractory to even Cabo. So I think when you use it, you get a familiarity with it, and you can go to it with a strong likelihood of benefit. It's that likelihood that when I give that and take that off the shelf and give it to a patient who really needs to have at least stable disease or some type of response, that I feel that 2/3 of the time or 75% of the time I'm going to achieve that with that therapy. And in my hands, Len-Ev does that, and I think the data supports that it does that.
Yeah, fair enough. I mean, I can't disagree with you there. I do think that, some of the dose-finding studies that we've done subsequently are complementary to some of those initial data sets and really do support some of that initial evidence. So I really can't disagree with you
So Monty,
at all.
can I just ask the question to the team here, and I'd like to learn from you all. It comes down to that belzutifan tivozanib person, because we know one of the neat things about tivozanib is that it tends to have a really nice, more gentler side effect profile. And you've been involved in that study, we've both been involved in the study, and we've seen long-term follow-up suggest that there's no accumulative toxicity. Belzutifan also, different mechanisms of action, equally seems to be well tolerated with some unique side effects. The concern that often comes to me, and people will ask me, what about that time to response? Or what are that period of time where you don't seem to have a benefit with the belzutifan? Does that make a certain type of patient not one you would give it to?
That is exactly it for me, actually, time to response. And I find that to be so unpredictable, right? You get that set of scans, right? It shows that there's 2 or 3 new lung nodules. You don't know if that's going to double or triple over the span of the next month or two, right? And it's a bit of a gamble. So, I tend to find myself using tivozanib just because I don't know whether or not that patient has rapid disease kinetics at the time they're first manifesting with progression for the most part, right? It's just highly unpredictable. Rana, your thoughts?
No, I completely agree. I mean, the primary PD rate for belzutifan from 005 is over a third of patients are going to have primary PD. The primary PD rate is actually lower in the tivozanib group when you look at that. So I do think that there is a phenotype that is going to be better suited for belzutifan. I think the flip from a quality of life standpoint for those individuals that can apt to get belzutifan, it's so nice to get a TKI break. They really relish in the TKI break when you're able to get that in and get it, get the treatment going. But I do worry about that primary PD rate.
Yeah.
I know you're going to tell us more about belzutifan, but I find that, that phenotype, if you will, of a clinically, responsive person who's very much HIF-driven, that's hard to tell, right? And it's somewhat of a clinical gestalt of what do we think is this person going to be, that sort of more indolent, more angiogenically driven, more HIF-driven tumor that might respond. But when people respond, they respond very well to belzutifan. And obviously the VHL population has that exquisite responsiveness, but I would love a biomarker to help us decide, right? And that very hard decision, should I pick something with a low primary progression disease, like tivozanib, or should I pick something that I know this person might respond to? And I'd love a biomarker for belzutifan.
I have a lot of questions about that. We're going to probably save those for after Rena's presentation. Definitely something I go to bed at night thinking about. Very, very interesting thought there. Brain metastases. Is there a preferred TKI in that setting, Tom Hutson?
Oh, gosh. No. There is, from going back from the beginning, first generation TKIs, there's always been interest in even things like sunitinib and its ability to penetrate. And going back from there's been concerns that there can be some penetrance, but it's not a reliable penetrance into the brain. So that's one of the concerns with that. With the checkpoint inhibitors, there's potentially some activity in the brain, but I'm still worried about, I think most people's cancers are going to be driven by the brain metastases. So you need to get the brain under control to get the prognosis back to a systemic illness. Without controlled brain, you have a 2-month survival. So it's really trying to get that back. But my experience has been, I don't have a preferred enough to rely on it, not like cytotoxic chemo, like testicular cancer, where you're like, okay, let's not mess with the brain, let's give them cytotoxic chemo. Sometimes we look up there and it's gone. Type of thing. I don't see that with the TKIs.
Yeah. I will say that in this particular setting, I do lean on cabozantinib pretty heavily. And, there's a paucity of evidence in general, but Tony and Rana and others have a really nice paper in JAMA Oncology.
So what's the reality of that? What's the
I think for patients that have asymptomatic, small brain metastases, you can get some effect in the brain with cabozantinib. So I think there is data. We were just chatting about this a little bit kind of in the break kind of leading up to this. There are some people that have, brain metastases with necrosis, edema that's seen. You radiate them, they still struggle. That's a situation where I actually lean on bevacizumab, and I actually work with our neuro-oncology colleagues to give Bev. It's not a very common scenario, but in the scenario where you are struggling and you have patients on steroids and they're continuing to have issues, I lean on that.
Yeah, for all the young folks in the room, the bevacizumab, right, was the first
Warren.
anti-
Warren, yes.
genetically looked at in renal
Minus the interferon, right?
There we go, exactly.
So speaking of adding or subtracting drugs here, lenvatinib, Tom, what is everolimus actually doing when you give everolimus with it?
That's a good question. I mean, there is a story. And so although people blame oncologists of just kind of throwing things at the wall and seeing what sticks, that's what we did in cytotoxic land. Historically, you wanted to have 2 agents that at least had some degree of individual activity and combine them and see if they produce synergy or at least additive benefit. But there was a story with everolimus and its ability to impact mTOR, and that seemed to make sense because it was working on, at least we thought in theory, that the mTOR inhibitors could work on reducing production of proteins like HIF, they could reduce that production. And so there was a thought with that. So not only did the mTOR pathway have its own ability through its gluconeogenesis and cell cycle traverse to have some effect there, but also there was effect on protein production, that there was a thought that maybe there was a benefit there. And so you're attacking that VEGF pathway, the VHL pathway, a different way, in that there could be at least an additive or synergistic effect. I mean, there was a thought.
Yeah.
So when you saw the diagram, you could give that story out there. Now, whether that's actually been, clinically, when we do the combination, we see, when you look at the curves, even from the basic science preclinical models, there seemed to be at least an additive benefit of the combination. So there was something happening, but I don't think we really know.
Yeah, well said. I know we're running a little over time, but I really do want to ask this last question. A patient comes to your clinic. What phase 1 clinical trial in renal cell carcinoma are you most excited about right now? Rana.
Most excited about? ARC-20 with a novel HIF-2 alpha inhibitor. I think that's, it's going to be interesting to see how that pans out with different combinations that are being tested in frontline and combination. Yeah.
I like that one. Tian?
I have one open of a T-cell engager,
Cool.
bispecific, that's showing some activity in kidney cancer. I think we need more targets in general. And so the Janux T-cell engager is the one I'm excited about.
Tom?
I like there's 2 trials by a company called Hypercell, two different assets. One works on a stress pathway, the other one was a PERK inhibitor. I don't know if they have formal names, but I know Rana always knows the names of these things.
HC7366.
Yeah, she knows all that stuff. So that combined with, one's being combined with TKI, the other's being combined with a belzutifan product. They seem to be really good. And what I call them 3rd generation therapies because they're novel targets and novel pathways.
Yeah.
Excellent. I'll make a quick plug for CAR-T, AB2100, CTX131. There's a whole slew of interesting CAR-Ts in development with very unique targets for renal cells. So lots of promising stuff out there. And with that, we're going to turn it over to Rana. We've had a lot of questions emerge around HIF-2, so you're going to tell us how to answer them.
Yeah, so super excited because I get to talk about the new kid on the block. All right, so we'll talk about the role of HIF-2 alpha inhibitors, both in sporadic and VHL-associated RCC. These are the objectives. We won't go through them for the interest of time. VHL mutations really drive the pathogenesis of RCC, and the finding that actually VHL is the predominant driver mutation in the early 1990s actually really led to all of the therapeutics downstream that have since been developed, both VEGF inhibitors and also HIF-2 alpha inhibitors. And this is work that we have done looking at sort of the prevalence of VHL alterations across different RCC subtypes. Over 80% of clear cell RCCs will harbor VHL. We do see some VHL across the non-clear cells as well, but not to the same degree that we see it in clear cell RCC. When we think about the HIF-VHL pathway under conditions of hypoxia or in the context of VHL loss, VHL is in essence a tumor suppressor gene, if you will, that flags HIF within the cytoplasm for proteasomal degradation. So when HIF is present, neurotoxic condition, HIF is flagged, and then it kind of gets degraded in the garbage disposal of the cell. But when VHL is non-functional, HIF will overaccumulate within the cytoplasm, dimerize, enter into the nucleus, bind to HREs, and then cause all this badness, VEGF production, and angiogenesis, metastasis, and so forth. And so, we are working on blocking that downstream, or I should say upstream pathway of VEGF. So the story around, HIF-2 alpha and its development, I know this is a CME, but I always like kind of getting a little bit of history in there, and this kind of stems with all the work that was done at UT Southwestern actually in the early 1990s or late 1990s, basically identifying, HIF as a potential target, and in 2003 actually identifying the pocket in the protein that could potentially be targeted. And Peloton actually developed the first therapeutic that was tested in humans in 2010. And actually, first publication was in 2018. And very short development time, Peloton Merck acquired the drug from Peloton and ultimately ended up leading to its first approval in 2023. So it's really been actually exciting to see, or first approval in 2021 for VHL disease and then 2023 for sporadic. So let me highlight the LIGHTSPARK-005 study. This is the landmark study that ultimately ended up resulting in the approval of belzutifan for refractory RCC. This study enrolled patients who had a clear cell RCC, who had progressed on prior VEGF and also progressed on prior IO, randomized patients to belzutifan at 120 milligrams daily versus everolimus. The primary endpoint was PFS and also looking at OS as a dual. And then you can see the breakdown for the treatment population. There were some patients that, had more limited lines of therapy that were kind of second line in this population, but also some heavily pretreated as well. And this is the top line data. This was a positive trial resulting in a statistically significant improvement in PFS. And when you look at the medians, you don't really kind of get a sense for the benefit from the medians, but if you actually look at the KM curves, the curves do separate. When you look at landmark PFS, you can see a separation of the curve with regards to PFS. No benefit from an OS standpoint, and I think some of us were a little bit surprised to see the lack of benefit there given the later stage in which this drug was tested. When we look at the response rate, and we've been kind of alluding to this response data, overall response rate just over 20%, but that primary PD rate is around a third, which is a little bit actually higher than what is seen with everolimus. So I want to kind of share some updated data that's going to be presented tomorrow during the RCC day here at GU ASCO, Abstract 538, presented by Guillermo de Velasco, looking at subset analysis from LIGHTSPARK-005. Here is just the data that was presented within the abstract, so you can glean. They looked at outcomes based off of bone, liver, and also some centimeter of target lesions, and see a kind of a consistent benefit across these subgroups. But hopefully we'll see more data tomorrow around this subset analysis. And then LIGHTSPARK-013 was a smartly designed study which was actually looking at different dosing paradigms for belzutifan, looking at both the 200 milligram Q-day dose and also the 120 milligram Q-day dose. And the 120 milligram is the dose that's actually FDA approved, and demonstrated that there was actually no difference with regards to efficacy in these two doses. Response rate in this heavily pretreated population was on the order of around 18% in both groups, and there was no difference there. You could see the waterfall plots almost look nearly superimposable. This work was led by Dr. Agarwal. And there was a nice meta-analysis that was actually conducted for belzutifan safety. This is a new drug with a different mechanism of action. It's different than the TKIs that we're used to. These data were presented at KCRS over the summer of last year, looking at a pooled analysis of the LIGHTSPARK series of studies, ultimately looking at outcomes for over 500 patients across these studies. And it was nice to see the AE data presented. Any cause high-grade AE was seen in around 60% of patients. Treatment-related AEs, 38% of patients. AEs that actually led to drug discontinuation, low, less than 10%, 6%. And I think one of the three key side effects with belzutifan are fatigue, anemia, and hypoxia. And when we look at sort of paradigms for anemia management, ESA use, which is like EPO-DARBI use, was at 23% in the context of these trials. Patients needing a blood transfusion around 17.5%, and then patients needing both around 12.8%. And it'll be interesting, in the discussion to talk about sort of AE management for belzutifan. And then the other piece to highlight that was really nice that was done in the context of this meta-analysis was the time to first onset of any grade AE. So when would you expect to see that anemia? How frequently do I need to monitor somebody's CBC? And then anemia actually tends to come on pretty early. You can see that the median time for the anemia there was actually within the first month, probably when people are coming in for their first, they've been on drug for a month, come in for your first assessment, get your CBC done, and then patients are anemic. So kind of be on the lookout for that. And similarly, the hypoxia too, average time is 31 days. And then the next study to highlight is LIGHTSPARK-005. This is a study that was looking at the combination of belzutifan plus cabozantinib, and there was several different cohorts in which this combination was evaluated. There was a treatment-naive cohort and also an IO pre-treated cohort, and you can see the response data breaking out for the cohort 1. Actually, particularly in the favorable risk patients, seeing a response rate of 79% for frontline favorable risk with dual targeting of the VEGF pathway. Lower response rates for the intermediate and poor risk patients, but still respectable. So you can see cohort 1 there, that treatment naive, a waterfall plot on the top right, and then cohort 2, which is the IO pretreated. And then I will highlight here that there are updates about LITESPARK-003 that will be presented tomorrow, abstract 549. Here is just what was in the abstract, just for your reference, and Dr. Choueiri will be presenting this data tomorrow, subset analyses in the context of this study. And I also want to highlight, we've already heard a little bit about the Keymaker study, U03 basket trial of pembrolizumab combinations, or belzutifan and pembrolizumab combinations in the IO VEGF refractory setting. Arm B4 looked at the combination of pembro-bel. Arm B5 looked at the combination of lenvatinib belzutifan. And you can see response rates here of 19% with pembro-bel. Kind of, in my mind, calls into question what is pembrolizumab doing in this context. And then the combination of lenvatinib-bel, this is, again, IO VEGF pretreated, response rate of 47% here. And so it's hard to tease out the contribution of the different components in the context of this study. But this data will be presented by Dr. Beckerman tomorrow. And then LITESPARK-011, we are eagerly all awaiting the results of this study. This is a study that is looking at the combination of lenvatinib at 20 milligrams plus belzutifan compared to cabozantinib, largely in the second-line setting, people that are IO exposed or IO VEGF exposed, with a primary endpoint of PFS-OS. And I do think that this study has the potential to change practice, so we are all eagerly awaiting the readout on the study's completed accrual and in follow-up. 012 is looking at various triplet regimens in the frontline setting compared to the backbone of len-pem. And so you've got len-pem-bel and len-pem quavolimab, which is basically a CTLA-4 inhibitor. This study has also completed accrual, has a dual primary endpoint of PFS and OS, and we're also eagerly awaiting the results of how this could potentially change the landscape as well. And then there's an adjuvant 022 study looking at the combo of len-pem-bel in the adjuvant setting. Just a brief word about VHL disease, historically described by von Hippel, who described these angiomas in the eye, and then Lindau described the disease that's seen in the CNS. Autosomal dominant disease, 80% of patients have an affected parent. We do see de novo emergence of this disease. Ultimately, all patients will express the syndrome by age 65, and about 2/3 of patients will actually develop RCC. And we've seen the work that's been led by Eric Yonash on the activity of belzutifan, particularly for VHL disease, high response rate, activity across other RCC lesions, the pancreatic lesions, CNS hemangioblastomas, and the retinal hemangioblastomas. And if we look at the disease progression rate, it's 0%. These tumors are exquisitely sensitive to belzutifan. You can see that waterfall plot, which is like beautiful. And, we won't spend too much time on this. There are other HIF-2 alpha inhibitors that are in development. Casdatifan is one that's fairly along the way with regards to its development pipeline. This is data from the ARC-20 trial. We will see updated data that'll get presented tomorrow with further data from this phase 1 study. We're not going to go into it here, but various subgroup analyses. And actually, they've achieved their recommended phase 2 dose, and we'll have data on that. And then NICANG, this is NKT2152, another HIF-2 alpha inhibitor with a pretty long half-life. We saw data that were presented at ESMO in 2024 by Eric Yonash on its activity. So I think we're going to see how this drug develops. And, this is just kind of a summary table of the different 4 HIF-2 alpha inhibitors that we've seen data on across the spectrum. Also, with regards to the dosing paradigm, their maximum EPO reduction, we see pretty substantial EPO suppression with casdatifan, and also actually the NICANG 2152 agent, and you can see the data that's presented thus far with regards to response and PD. So in conclusion, VHL is highly mutated. Nearly 80% of patients with clear cell RCC have VHL mutations that drives pathogenesis. HIF-2 alpha is a validated therapeutic target. Belzutifan is the first FDA-approved agent that is a HIF-2 alpha inhibitor in this disease. There are on-target toxicity related to Bel, anemia, hypoxia, and it's being looked at in various combinations, and there's other HIF-2 alpha inhibitors that are being developed. So sorry for the going over a little.
No, that was perfect, Rana. Thank you. Excellent talk. I have to say, I always pick up, several pearls, and the von Hippel-Lindau history is something that I wasn't aware of. So thank you for that. That was actually super interesting. And we actually have a lot of really tough questions actually embedded within this discussion over here. So I don't know that I need to come up with too many of my own zingers for this. But what I will ask is, and Renal, I'll turn this to you since you just gave this very eloquent presentation. Screening for VHL alterations. Do we need to do it in all patients now with belzutifan being available?
Very good question. I don't think we know the answer. I think that, the purist in me would probably say yes, but I don't think we know the answer. And I think we really need data to sort of showcase, is the presence of a VHL mutation actually predictive of response to belzutifan? And I don't know that we know. I think in clinical practice, I do have non-clear cell patients who have a VHL mutation, who are refractory, who I would use belzutifan in because of a lack of treatment options, but I don't think that we know.
Yeah, I'll tell you what, this is probably the number one question that comes up in my discussion with referring docs. Should we potentially, get germline testing for this patient? Should we necessarily get somatic testing, et cetera? The discussion I usually like to have is, well, what we've been doing all along the way for our patient is treating with VEGF inhibitors along the same biological signaling cascade, right? So, I agree with you. We just need more evidence before we start getting somatic testing for everybody. I guess the teachable moment is around appropriate indications for germline testing. So, age under 46, bilateral renal disease, first-degree relative, et cetera. Those are all the settings in which we think about doing germline testing, and that's usually the discussion I like to have. Tom, this next question's around, really, I think, drug development in the space, right? I mean, are HIF-2 inhibitors best sequenced earlier? Is it better to use it in front line versus second line versus third line? What do you think?
Well, I think it's going to come down to the magnitude of benefit from these trials that we're doing. So we need to see the efficacy there. I think we've all shown, we all believe, and we've seen the data both retrospectively and we've seen it in clinical trials, that there's attrition of patients as they move from first, second, third, and fourth line. So if we can show that we have a more active regimen that is tolerable, but we actually get meaningful efficacy endpoints, then we need to be using that as early as we show it's beneficial. So I'm not someone that believes in saving something for later, because you don't guarantee your patients will get to that later point. So that means if these triplet or quadruplet types of trials show that there's an absolute benefit, then we need to go for it and we need to use them all up. Now, some of me's a purist, and I'm back, having gone to medical school in the 1990s. We like to show that there's sequential use of single agents is, that the combination's better than sequential use of single agents. So you'd like to know that you're not just kicking the bucket or doing anything with the combination. But I do believe, like I said, that combination approaches should be utilized if they're shown to be efficacious and tolerable for it. And just to go with the last question you said about comprehensive genome testing, I'm a supporter of doing that in all patients with metastatic disease. We're moving into a stage now in cancer therapy, which we've seen with pembrolizumab as an example. We see it with vemurafenib with V600E, this tumor agnostic approvals of therapies based on a mutational status. And so everyone that's coming to me in my new place and everyone that was started at Texas Oncology and Baylor, we are now getting NGS in really all of our metastatic patients. And we're hoping to collect that in a database that will help us for future drug discovery. So in that manner, I would recommend NGS for metastatic patients.
Yeah. I suppose it's probably not a contentious issue in many cancer types. What about renal cell, Tian? I mean, are you profiling all your patients walking through the door?
I don't profile all of them. I do profile patients who are younger, and some of the variant histologies. I will go after some sequencing. The most, clear cell kidney cancer, because we don't have a targetable mutation in that refractory setting. I'm not routinely testing right now, but I think it's a good source for research, as Tom has pointed out. And hopefully we do find some good targets to go after in future settings. And if so, if we have approved targeted therapies in that refractory space, then that would be one reason to have routine testing for all.
Interesting, yeah.
I think, Monty, just a question for them all. Do anyone on the stage feel that it's going to be a de-intensified regimen of one or two drugs that cures this cancer? Or, or do we think it's going to be like many of our other regimens that get the job done, which is going to be a multi-pronged attack with a variety? And
Yeah, no, absolutely. I mean,
Yeah.
I think it's going to be a multi-pronged attack,
Yes.
and I think we've got to figure out a way how we can leverage IO. You know, we've already made great gains with Nivo/Ipi. How do we take that tail on the curve from, 10 to 20% to 30 to 40%, like is being seen with melanoma? Are we going to do it with additional IO agents? What role is VEGF going to play in that? What role is belzutifan going to play in that? So I think that it's going to be really exciting to see what the future holds.
And Monty, it's probably not all, and Tian, you may agree with this, it's not going to be based on your pedigree trial. It's probably not starting off necessarily with everything at once on day one. It may be this is a regimen you're going until you get to a certain point, like stable disease or something, then you're adding something in, CAR T therapy or cellular immunotherapy, something else to kind of continue to work. I mean, I see that type of an approach, those novel designs and trials.
Yeah, I can definitely see the crystal ball holding something like that in the future. Absolutely. In present state, though, right? Let's say somebody walks into your clinic, Rana, very educated patient comes in with their Tempest report or what have you, and says, "Well, Dr. McKay, I've got a SETD2 mutation. Doesn't say VHL here anywhere, but you want to prescribe to me belzutifan. Why?"
Well, I mean, I think that if they're clear cell RCC, I mean, it's the pathway that's driving the disease. The other thing that I will say is, what specimen got sequenced? Was it an adequate sequencing report? I just don't think we yet have the data to deny somebody who's clear cell getting belzutifan in an era where we don't actually have a ton of drugs with different mechanisms of action. I wouldn't ever hold something back because of a report that said that they lacked a VHL mutation. So I think it's certainly an area for discussion, but we haven't proven that a lack of a VHL in a clear cell patient is evidence of lack of response.
Yeah, I tend to agree with you. On the subject of genomic profiling, I always wonder if it's, one of two things that drives sort of this diminishing return with belzutifan across lines of therapy, right? I wonder if it's the protoplasm of the patient, right? They're progressively, less functional, more anemic at baseline, et cetera. All these things sort of limit our ability to deliver therapy. And then, as I think you've alluded to, I wonder if the biology changes, right? Maybe they take on a more anaplastic phenotype. Maybe VHL is a less critical driver of the disease in that setting. So I think these things can definitely change over time. Some of these questions are somewhat interrelated, so I'm going to blend these together. And maybe I'll lean on one of the questions that's spelled out here more concretely. How do you pick between tivozanib and belzutifan, Tian?
Oh, gosh. Well, we touched on that a little bit earlier. But I do think, does this patient need early, a strong, high percentage of stable disease or better, right? They cannot afford a primary PD. If that's the case, then I'll think about tivozanib. Are they really just indolent and angiogenically driven, and I'm getting the clinical gestalt that they're slow growers? That one might be a belzutifan candidate.
Yeah, I think that makes sense. Tom, I see you nodding your head. Generally
Absolutely agree. And I think Rana had mentioned before about, sometimes people just need a break from a TKI. And so they're, you just want to go with something that just gives them that break.
Yeah, it makes perfect sense. I actually purposely allocated a good amount of time for this set of questions over here, and I want to do these in reverse because behind the question of genomic testing, the second most common question that I'm asked about with respect to belzutifan is management of anemia. This is really, really complicated, I think.
Yeah.
Maybe I'm overthinking it a little bit here. Yeah. But I'm going to ask each one of you to maybe give me your perspective on when you jump in with growth factors to manage anemia. This is something that we don't really have good concrete guidance on. So, Rana, maybe you first.
Oh, yeah, absolutely. So I, for individuals that are on belzutifan and they're beginning to get anemic, I do use growth factors. I do not wait for them to develop grade 3 anemia and then hold drug and then dose reduce. I just don't think that that's an appropriate paradigm. First off, up front, doing everything you can to maximize, are you treating any reversible causes of underlying anemia? Does this patient have iron deficiency? Do they have B12 deficiency? Are we checking an iron panel, checking their ferritin, replacing them appropriately? And then I track their, hemoglobin levels. And if they do start to dip below 10 and get into that grade 2 range, I am introducing an ESA to help keep them up and prevent them from ever needing a blood transfusion. And usually you kind of will give 2 or 3 doses and they kind of bounce right back. I do monitor for hypertension in the context of introducing an ESA and give instruction around that. But I do think that there is value, especially at this stage of the disease. We're using belzutifan in a heavily, more treatment refractory setting, and I do think that I do think it's appropriate to introduce an ESA.
So I see you nodding your head, Tom. So I assume in general you agree.
Yeah, I think that's brilliant. I think that's a lovely way to approach it. And I think it's important if you're going to be a practice that does see kidney cancer patients that uses belzutifan, which I encourage you to, that you come up with some type of standardized way of approaching that.
Yeah, so Tom, patient walks into your clinic, right? And you start them on belzutifan, they become anemic, just as Rana suggested, and you've got EPO top of mind for that patient. And the patient walks into your clinic with a stack of papers that says, wait a minute, I've done my homework here, and the history of this class of growth factors is very complicated. How does that conversation look?
I think, first of all, we need to put things in perspective and say that, a lot of that data came out and was driven from a review of breast cancer and outcomes of that in the metastatic setting versus in the adjuvant setting and the impact there. But you're in a situation where you have a specialized molecule that's been designed that actually targets one of the ways the body utilizes its factors to tell it when we need to make blood. And so what we're doing is essentially, we know there's a relationship with EPO and HIF. That's a direct relationship. And so as you inhibit HIF, you potentially can drive down EPO levels. And what we're doing is giving you physiological replacement. I'd kind of talk it that way, whether that or not, Rana will tell me if that makes sense scientifically.
No,
But,
I mean, absolutely. And then I also think the context, where is that patient on their runway of cancer where there's going to be a risk from the ESA? These are later stage patients. What's the overall survival of that individual when you're actually introducing belzutifan? A year and a half? So I think when we're kind of balancing the risk benefit, it just doesn't pan out,
Yeah, so I'm going to pick on Tom a little bit because he's a pharmacologist also, on top of being a world-class physician, and I've seen him give brilliant talks on the subject here. So the patient actually has a PhD also in pharmacology, and actually says, well, Tom, I've been over the literature and I've seen the phase 1 data, and gosh, when we're looking at HIF-2 inhibitors, it looks as though EPO levels are actually a pharmacodynamic biomarker of activity here, right?
Yeah.
And you're giving me EPO. What the heck?
Well, that's because with HIF levels, the EPO goes down. You're blocking HIF, and HIF is, again, one of the ways the body normally regulates, one of the factors that is involved in the regulation of EPO, of just endogenous EPO. And so we're actually helping the body. But there's no effect that giving EPO is somehow going to have a negative effect on your cancer. I mean, we have no reason to think that. There's not going to be any loop that's been proven that way. It has not panned out. The clinical trials that were done, are you going to say that that's not true?
No. I completely agree with you.
Yeah.
I would support you.
Okay, good. Because, I would think that, in the clinical trials that were done, EPO was one of the ways that was given. And in that trial, you got these benefits. So there should be no reason to want to avoid it.
Yeah, brilliant. I'm convinced, but Rana, you can
No,
add more.
I was going to say, this comes up a lot. It also comes up in the context of dose reductions, dose modifications. Am I still going to reap the benefit that was seen in the trial? And in actuality, yes, because the patients on the efficacy data that is presented is reflective of what happened to the individuals on treatment. It's reflective of the dose modifications that took place, the dose discontinuations, the utilization of ESAs. So that portfolio ended up yielding X efficacy data. So it is looped into that. So I try to explain that, in discussions with patients that's okay. These trials, when patients are on these trials, they're not maintained at that dose in this paradigm the 100% of the time that they're on treatment,
That's right.
Yeah, well said. Like I said, I'm convinced. You've sold me on this. I appreciate that. The second bullet point over here, because again, we're going in reverse. I think we could probably all concur that PFTs aren't always necessary, ahead of doing HIF-2 alpha inhibitors. This first question is one that I struggle with a lot: management of hypoxia. So a patient comes into your clinic, Rana, you get pulse ox, and it measures at 93% resting. What do you think? In a scenario like that, are you using Bell? Are you kind of holding back a little bit? Let's say the patient's been through 3 prior TKIs.
I mean, if they don't necessarily have additional treatment options, I am using belzutifan. We're closely monitoring the patient. We're giving them instructions, or I may tell them go on Amazon and buy a pulse ox. Let me know how you're doing, how you're feeling. I think if they do drop down below 92, 90, thinking about a dose modification. I think where I've gotten actually a little bit burned with regards to the hypoxia is in patients who actually have lymphangitic spread and have sort of kind of like, not to say occult high volume disease in their lungs, and you can really get into trouble. So I think, really making sure that you're looking at the patient's CT scan. Do they have a lot of fibrosis, interstitial scarring? Do they have underlying COPD? I think these are all things that can impact the utilization of belzutifan.
Yeah, brilliant. It's a bit of a challenging situation with lymphangitic disease because you assume that's a very rapid growth pattern. And you think about using belzutifan where the kinetics of response are kind of slow, right? So it's a very, very tricky situation. Very, very tricky situation. One last zinger here for you, Tom. What if that patient's pulse ox was 91%?
Sure. I think it's the same thing. Where are you at in your treatment? What are your other options you have? But if it's that, when it's the one and you just have that shared decision-making process with them, and what I found in my experience, they get their pulse ox. Some of them are actually lowering the dose before even calling me. They've done things because they watch it. Sometimes all they had, as that drops, all they need to do is get up and move around a bit and it comes back up. And so it's just really education and keeping that line of communication up with you. And
great point. Tian, you were going to mention something?
Well, I was, when we see that, and, I would get a walking sat, right, making sure that at baseline they're not dropping into the 80s. But then also, when we're seeing hypoxia on treatment, we're also, starting patients on some ambulatory, supplemental oxygen, holding, dose reducing, and all of those supportive care factors are really important to getting patients, maintained on treatment.
Brilliant. All right, great discussion around this. I'm going to round things out with a discussion around non-clear cell kidney cancer. We'll go through some tough questions around this particular clinical setting, and there certainly are many. We're going to really take an approach that really limits discussion around biology. There's a terrific review paper written by several outstanding fellows, one of whom, Nazli Disman, is in the room with us here today. And I'm actually going to also skip over this really, I think, well-done table by Rana and one of her medical students, right? Which actually is in Therapeutic Advances. It really is a nice description of all the genomic alterations associated with non-clear cell RCC. But what I will say is this is a very heterogeneous disease, right? It's not by any means a singular disease. And so the approach that I'd like to take on today is to really kind of go through each one of these diseases one by one if possible. So we're going to start with a study that's near and dear to my heart, PAPMET, which is also known as SWOG 1500. So this was a randomized study conducted in patients specifically with papillary RCC. That's about 10 to 15% of all patients with RCC. And it randomized these individuals to either sunitinib as a control arm or cabozantinib, crizotinib, and savolitinib. And the premise of this study is that papillary renal cell carcinoma is a disease that's driven by MET. So the thought here is let's use some MET inhibitors and see whether or not we can improve outcomes. What was actually quite interesting here is that the pure MET inhibitors, crizotinib and savolitinib, really failed to improve clinical outcomes relative to sunitinib. And cabozantinib, with these dual MET and VEGF blocking properties, seemed to offer some advantages in terms of progression-free survival. Now, Pedro Barada, a terrific young investigator from Cleveland, actually updated this data. And what's quite interesting is that at this point in time, we haven't demonstrated any survival advantage. So I would say the standard of care in papillary renal cells still remains to be determined. So what does the future hold? There's data for cabozantinib and atezolizumab in combination. Atezolizumab truly really hasn't panned out in renal cell to date. But the response rate in papillary RCC was pretty respectable at 47%. Kelly Fitzgerald and Joe Lee from Sloan Kettering, now Kelly's at UCSF, put together this really nice distillation of data on cabozantinib and nivolumab in an updated report. They also produced a response rate of 47% with cabo and evo. So this is great data. But I want to emphasize here, and I'll keep doing this in this particular section, these are all single-arm trials, so I don't think we can necessarily hang our hat on this. Bev-atezo, a regimen that had modest response rates in clear cell renal cell carcinoma, also has modest response rates in papillary RCC at around 25%. What I think is looked at as being quite promising is the combination of len-pembro in this setting. Again, a multi-kinase inhibitor makes sense in non-clear cell disease where the targets are varied. And the response rate in papillary RCC, when I sort of weed that out of this very large study, was around 54%. Now, what about specific MET inhibitors? When we look at them in papillary RCC alone, as I'd mentioned in the context of PapMet, the data didn't look too compelling. But in a single-arm series, if we actually ferret out those patients with MET-driven biology, you actually get a healthier response rate of around 18% or so. So one of the issues in PapMet, that randomized study that I presented to you earlier, is we didn't ferret out those patients who had MET alterations from the get-go. It took all patients with papillary RCC. So there might actually be some rationale in identifying MET alterations and then treating the patient with a MET inhibitor. This was taken a step further by Cristina Suarez on the right with savolitinib and durvalumab. So with this MET inhibitor IO combination, you can see really healthy response rates of around 53%. So what's next in papillary RCC? People often say, well, gosh, these single-arm studies are great. Let's jump to these in the clinic. I say, wait a minute, let's really be purists here and see if we can do randomized trials. So in the top left is a study that's being led by Ben Mon from the University of Utah. It's a follow-up to PapMet. It's called PapMet-2, and it's cabozantinib plus or minus atezolizumab. And this is an important study restricted to patients with papillary RCC. There's a study that, in my mind, maybe has a little less biological justification called PAXI-PEM that's looking at axitinib and pembrolizumab versus axitinib. Axitinib may be a little less substantiated in the context of papillary RCC, but this is being done in France. The two studies that I really want to emphasize for folks in this room, and we certainly need support, particularly the one on the bottom left, is Stellar 304. This is a trial looking at zanzalintinib with nivolumab. I'll mention this a bit later, versus sunitinib, and the Samita trial is using a MET-selected approach looking at savolitinib durvalumab versus sunitinib versus durvalumab. So building on some of those single-arm data sets that I showed you previously. The trial on the bottom right is a very ambitious effort. It uses MET-selected patients. Just summarizing the data here, the top two trials are randomized phase 2s. The bottom two really, I think, have the ability to change practice as randomized phase 3 clinical trials. So, when these results read out, I really do think they can have a potent influence on practice. Tian already gave us a nice overview of zanzalintinib. Zanzalintinib is really, a novel VEGF/MET/AXL inhibitor with kinase properties that might seem somewhat similar to cabozantinib, but clearly I think the activity here is quite unique. And I'm going to focus your attention into the bar graphs on the top right, where you can see that in patients who have gotten prior cabozantinib, you can see that if patients did not receive prior cabo, response rates were quite high, 57%, but even in those individuals who'd received cabozantinib previously, you have a respectable response rate of 24% and a disease control rate of 94%. So I think this is something quite unique. And we're going to be testing this formally, as I'd mentioned, in Stellar 304. The study's well underway. We have several sites open throughout the United States, many sites ex-US as well. So I'd certainly encourage you to enroll patients to this trial. It's not just for papillary disease. We're also enrolling patients who have unclassified histology and translocation histology in this trial. Now, some of you may have looked at the studies on the previous slide and said, well, gosh, why is sunitinib the control arm here? I thought we just got through PapMet, thought that had sort of established a standard. Two things. One is that I think that the results of studies to date have not firmly established a control arm that's rational for these trials. I'll give you an example here. I got this denial letter for a patient when I tried to issue cabozantinib for a patient, and instead it favored sunitinib, right? And this is in 2023. The results of PapMet were, well out at that point in time. If we look at EAU guidelines for what they recommend that we do for patients with papillary RCC, you can see that regimens like cabo actually have a weak recommendation. So again, I think the jury's still out, and these randomized trials with a sunitinib control arm are very reasonable here. Chromophobe RCC. This is a real challenge. A person who's taught us a ton about this is on the stage, Tom Hutson, who published the data for lenvatinib and everolimus. And in particular, I'm really glad, Tom, that you focused on this subset of individuals with chromophobe RCC. It's not a huge experience, 9 patients, but it's data that we have in hand, and it has a very good response rate of 44%. So this is a regimen that I use frequently, actually, for my chromophobe patients. I think the data that Laurence has produced on the right for lenvatinib and pembrolizumab also very reasonable with a response rate of 28%. So again, in a patient with chromophobe, I really am leaning towards len-based therapy. collecting duct carcinoma. I think the conventional dogma in the clinics when I see patients with collecting duct RCC is treat them like urothelial cancer, right? Use platinum-based chemotherapy. I think this has recently been challenged by Giuseppe Procopio, who's pictured on the top right over there, a brilliant Italian investigator who I think kind of did the impossible. In a contemporary trial, he looked at cabozantinib in patients with collecting duct RCC and produced a response rate of 35%, which is very impressive. There's one person who's incredibly focused on curing this disease, renal medullary carcinoma, Pavlos Musel, who is based at MD Anderson, and he's really done the lion's share of work, I think, in pushing trials forward in this particular clinical space. I'll tell you, the data here is not mind-boggling, but it's better than anything we've seen to date with doxorubicin and gemcitabine. We have a response rate of 19%, with bevacizumab and erlotinib, a response rate of 20%. He's also got an algorithm that he's proposed. I actually built this after a discussion with him, where he likes to start patients initially on platinum-based chemotherapy. He likes to go to gemcitabine and doxorubicin next, maybe consider EGFR-directed therapy in that particular setting. And all of these are referenced in case you want to take a look at the response rates and efficacy associated with these strategies here. My friend Ram Srinivasan at the NCI has dedicated a lot of effort to HLRCC, hereditary leiomyomatosis, and renal cell carcinoma. This has undergone some changes in designation by the WHO recently. But if you look at the data on the left-hand side, very impressive response rate of 72%. Now, this has been presented multiple times. We're really sort of pushing him to start publishing this data so we can see it in printed form, right? But having said that, at first blush, this is certainly an impressive data set. Translocation RCC, again, this is an area that needs further research, and I'll point out that Stellar 304 trial that I highlighted previously includes patients with translocation renal cell carcinoma. Here I would suggest that it looks as though there's good rationale for utilizing VEGF-targeted therapy with ICIs in combination. It might support, for instance, the premise of Stellar 304, but again, there's really no standard of care in this particular context. I put here some more recent data from KEYNOTE-B61, that trial of lenvatinib and pembrolizumab. This particular slide offers in tabular format, really kind of in graphical format, a nice distillation of how lenvatinib and pembrolizumab performs across some of these rare histologies. So in an update, you can see here that chromophobe histologies are associated with a response rate of 35%, unclassified 50%. Take a look at the denominators, though. We have between 6 to 10 patients in some of these subgroups here. So I think it just underscores the fact that we need good randomized data. How can we encourage our patients to find trials? KC Cure, the Kidney Cancer Association, these groups have really done a ton of tremendous work towards leading patients towards studies that are ongoing, like Stellar 304, like Sameta, et cetera. So some takeaways here. There have been randomized phase 2 studies been done. We have great single-arm studies done in very controlled settings. We have to, I think, get some randomized data here. And these studies certainly need your support. So I'll wrap up there and we'll move to some questions. Okay. So, we went over an overview of the various treatments that are available for non-clear cell renal cell carcinoma here. I just gave this presentation around how, in this particular scenario, we really sort of need to lean on individual histologies to determine the nature of the therapy that we're rendering here. Is that your approach, Tian, or do you tend to be more of a lumper or a splitter in this context?
Yeah, no, I do think we need to really think about each histology separately, just as you've sort of taken us through each of the histologies. So I don't, bucket them all as non-clear cell, and I think we should be thinking about the biology of each to hopefully find the strategies to treat them appropriately.
Yeah, that makes sense. And maybe we'll go to some specific scenarios here. So, Rana, this third bullet point over here, I want to get your opinion on this. 64-year-old patient, let's say good functional status. Let's say they have a fairly indolent pattern of metastatic disease, not incredibly rapid tempo of growth. What are you recommending for them for metastatic papillary histology?
Very good question. I think I struggle with these scenarios. What I struggle with is, do I give them Nivo-Ipi, or do I give them Nivo-Cabo? When we look at the data of Nivo-Ipi for the non-clear cell patients, the primary PD rate is double. It's goes from 20 to 40, and the objective response rate is 50% cut in half, dropping from 40 that we see in clear cell to 20. That being said, the data that we know about IO therapy is that earlier is better upfront. And if there's any tail on the curve, it's from early upfront use. So I struggle with that. And I think that if I have somebody before me who's got indolent disease, who's 64 years old, they're doing well, I kind of want to give them a chance of upfront IO, understanding that I'm gambling. Like the primary PD rate is very high with Nivo-Ipi, but if somebody's got indolent disease, I can chance it. And it's that discussion that you have with the patient, the alternative, I think, of Nivo-Cop. I'm going to send them to Monty, actually, to get them enrolled on.
Oh, thank God. Okay, thank
on
you.
your
Yes,
trial.
that's the right answer.
I'm going to definitely do that, But it's a struggle. I don't think that we really have a right answer. Yeah.
Yeah, no, and thank you for that shout out. I mean, I definitely think this is a setting where first and foremost, we're definitely thinking clinical trial, right? Because there's really no clear standard of care. But, in fairness, I did kind of take that clinical trial option off the table. One study that I actually did cover is the Sunny Forecast data. And so, Rana, I'm glad actually that you brought up nivolumab and ipilimumab in combination in this setting. Tom, I see you nodding. Are you thinking about Nivo-Ipi after seeing the Sunny Forecast data or not?
Not as much. I'm using, generally more Cabo-Nivo as my first go-to. I still remember the point when we didn't have the IO-TKIs, and we did have, data. Cabo was there as a single agent. We knew that lenvatinib everolimus had some degree of activity. At least we studied it in non-clear cell. And you still were left, like you said, with sunitinib first. So what happened is Cabo-Sun got approved, and so there was an FDA approval for Cabo, so I would be able to give the Cabo first line as a single agent. So a lot of it's dictated by what you can get paid, too, outside of a clinical trial setting. And it wasn't just a few years ago. We didn't have a lot of clinical trials in the papillary type. So thankfully we do. And certainly patients should seek out expert care or referral, whether that be the local oncologist calling one of their regional center of excellence and talking to someone about what would be best practice. But ultimately, you do have some patients that just can't travel for clinical trial, and then you're having to choose. But at least the most recent updates of the NCCN guidelines at least give recommendation, which will hopefully aid in the approval process for the drugs, of using an IO-TKI type regimen. If there's someone that you really think that they're very indolent, because some papillaries can be very indolent, but you still feel like you need treatment, then you could always give single agent cabozantinib. It does have an approval.
Yeah, and I tend to agree with that. Sunny Forecast was a tough one for me to sort of sit with. It was a study with interesting endpoints, to say the least. They looked at 1 year overall survival in this trial of nivolumab and ipilimumab versus sunitinib for patients with non-clear cell RCC. So, I have my reservations about the relevance of that. But, to your point, Rana, I mean, there are some patients who did appear to get protracted benefit. So it's a tough choice. I can definitely see that. Tom, you come at this field with experience in both, community-based setting as well as academics. What do you think is the role of pathologic re-review in patients with non-clear cell RCC? Is that something that you're requesting when you're, sort of based at a community site routinely?
I'm not requesting re-review of pathology unless there's a behavior in the clinical scenario that sends a red flag for me. So it's got gut feeling you have based on, I always tell the oncology fellows that you're supposed to be the expert of the natural history of the disease. And so if you see something that doesn't follow the way it's supposed to be in response to therapy, and then I'll look for those. Certainly younger patients and things like that, where I'm trying to look if there's any hereditary translocation associated component, I will do that. But in general, that's plagued us. And it's been an issue for the cooperative groups. It's plagued us back from the days of the original sunitinib trial, where many of us, we didn't have therapy, so we were trying to get people on this, the Nexavar, the Targets trial, and the sunitinib trial, and all you needed was a component of clear cell. Yeah. So you're getting and so you wonder what was really the breakdown of the patients. All you needed is the pathologist to say they saw a component of clear cell.
Yeah.
Right.
What that really was.
Yeah.
I'm still bothering my pathologist to get me a component of clear cell.
Yeah, no, absolutely. And to comment on sarcomatoid, the presence or absence of it. I think that I want to see those two things. Yes, I see sarcomatoid, or no, I don't. And if it's not written in there, I don't know if it's there or not. And, sometimes we see these RCCs NOS that you're like, I need to know.
What is that?
What is this? So, I definitely will.
So in that situation, you would probably, if it was an outside institution, you would probably give a lot of thought to, especially if you're a clinical trial institution, of redoing the pathology. Yeah.
Yeah, any grade 4 should be looked at for sarcomatoid if it's not.
So let's go through some specific histologies here. I hope I haven't biased the conversation too much with my perspectives on each one of these sort of rare tumor types here. Tian, patient comes to your clinic with metastatic chromophobe RCC. What are you typically offering them in the frontline setting?
Yeah, our IO doublets are really terrible for chromophobe disease. I hope we get to a place where we have ferroptosis inhibitors, but for the moment, I think Len-Ev looks reasonable, and I'm thinking a lot of trials. There were a couple of responses on Len and Pembro as well on B61, although to your point, smaller numbers. But it's hard to treat chromophobe, especially in the metastatic setting.
And let's stay on that theme, though, with maybe Len Pembro as our upfront approach. And maybe let's go beyond chromophobe, because I agree with you, is a very, very sort of difficult histology to treat. Let's assume patient has papillary disease or maybe unclassified RCC. You saw their Len Pembro is generating some very healthy response rates. If a patient progresses on Len Pembro with papillary or unclassified, what then becomes your second-line strategy for that patient?
I think if it's papillary, I'm looking at cabozantinib based on PapMet data, and if it's NOS, I'd also be thinking about cabo, but some of these NOS type of tumors, they do progress very quickly on each of our standard therapies, and so I'd be doing some maybe genomic sequencing, some re-review. There's a new HER2 tumor agnostic indication for an ADC, and I don't see a lot of HER2 in kidney cancer, but on that off chance it's like an upper tract urothelial / collecting duct, maybe it's there.
Yeah. Yeah. Well, let me ask you, Rana, again, in a sort of histology-specific fashion. So Tian tackled chromophobe for us, renal medullary cancer. This is a tough diagnosis to see in the clinic, isn't it? I mean, it's tragic just from the age of many of the patients that walk through the door, the rapidity of the disease. What's sort of your mainstay in the frontline setting?
Actually for renal medullary, they don't do well with VEGF or IO. These patients are treated more almost like a urothelial cancer, if you will, platinum-based chemotherapy options. I'm definitely thinking of clinical trials. I'm definitely genomically profiling them. I do not give these patients upfront IO combos.
Yeah, it's so interesting. I think about that slide that we showed, courtesy of Pavlos Masoul from MD Anderson, and it brings out gemcitabine and doxorubicin, and Tom and I were taking this trip down memory lane, and that was a regimen we looked at in ECOG 8802, right? And the 88 there tells you when that study was conceived, actually. So these are old regimens that we haven't picked up in renal cell carcinoma for literally decades that we're throwing into renal medullary cancer. So agree, that's definitely an area where we need, I would say, lots and lots of progress. We've touched on a lot of these particular concepts over here. Where does TKI monotherapy fit into non-clear cell renal cell carcinoma? We talked about cabozantinib and papillary disease. Is there ever a situation in which, Tom, you don't prefer a clinical trial for your patients in the upfront setting with non-clear cell RCC?
If I had a clinical trial, I really would. It would be, again, I guess if there was something with the patient that made them they didn't want to participate in the clinical trial, because remember, despite the convincing, they just may be in a situation, their age, their comorbidities, the ease of which they can travel back and forth to clinic. I'm in rural Texas now, so that factors in. They may not be able to get back and forth to the clinic enough to do those extra assessments that a clinical trial requires. Then in that situation, I would consider using, like we've already said, that the drugs that we've talked about, the newer generation of the VEGF TKI seem to do the best in that situation, and the IO combinations is what.
And this is really a question for the panel. I'd love to hear your thoughts on anything that's in pipeline. Tian, you gave us a brilliant conversation around novel agents for clear cell RCC. Is there anything in pipeline that you guys are excited about in non-clear cell RCC?
I'm looking forward to the zanzalintinib 304 trial that you presented. I think that we should go really drill down on each histology and figure out what works in that particular histology type. some of these interesting ADCs are, what's overexpressed? Can we, find the target on those particular variant histologies that we can go after and, deliver, smarter type of targeted therapies. So that is the type of, I don't have anything in my shop right now, unfortunately. I'd be curious to hear, if you all have other targets that you're excited about.
I think about this a lot, and I've always been intrigued at how our lung cancer colleagues target MET. They've got so many unique strategies, bispecifics, et cetera, that are going after MET, and I just wonder if those really hold promise in renal cell carcinoma. At this point, I don't think we know. One thing that I think I know all of us are pushing for is if we have a target that we're exploiting that's novel in clear cell RCC, we're pushing companies to look long and hard at whether or not it's expressed in non-clear cell histologies as well. Tom?
Yeah, that's why I support this concept of getting NGS data and just whatever you're doing in your biobank or what you're collecting your data to start really trying to look at what's showing up in a sequence of people you're testing. Is there a potential target there? And then trying to correlate that just with your own institutions, looking at the efficacy of your various agents. Thankfully, AI and some of the new platforms coming out really allow you to pull everything together and start looking at that. But one of the things that the FDA, in its infinite wisdom back in 2005, 6, and 7, decided to think of kidney cancer as one disease. And so they gave these broad approvals that we've never really seen in other tumor types. If you're not studied in that exact type in your clinical trial, you didn't get that approval. But they gave really kidney cancer drugs this broad approval. Clear cell, non-clear cell, didn't matter. Some were approved no matter what line of therapy. They just got these broad approvals. And that really hurt our ability to do these non-clear cell trials, which really in many situations are orphan diseases. They're rare enough. And so I applaud pharma companies that are actually investing money, especially companies where they already have an FDA approval, and it's not going to affect their label because their label already is broad, but they're supporting development or at least an understanding of the therapy. And I remember the KCI was invited to I think Monty, you were there, maybe Tian was. It was one of the meetings that they had before the meeting where we talked, brainstormed, and one of the topics was non-clear cell histologies, and it just really came up. It's really hard for pharma, who already has an FDA approval that's broad, to want to invest in understanding. So that's where cooperative groups, and thank you for Monty for chairing that, and thank for the others for the other cooperative groups. That's the only way we're going to answer these questions.
Well said. Well said. Well, guys, this has been just a brilliant conversation this evening. Rana, Tian, Tom, thanks so much for letting me put you on the spot. And everybody in the audience, thank you for spending your Valentine's Day with us. So with that...
and can we give a round of applause for Monty
Yeah.
for being an amazing moderator? Coming up with all the cases, keeping us engaged. So thank you, Monty.
You're too kind.
Tremendous job.
Oh, happy Valentine's Day, everyone.
Thank you.